everybody.
Pro bono.
And first I want to apologize for Jerry. He's not gone fishing as in he didn't want to be here. A couple months ago, his wife planned a family vacation. And I'm not sure where Jerry was in the decision process of it. But it ends up that it came and he asked me to do this in his stead. So we want to make sure we have somebody that can represent here. As far as my background, I'm the manager of clinical services at the ADM board. Prior to coming here, I held the same position at the Lorain County board. I am former president of the State Chemical Dependency Licensure Board. I'm faculty at Cleveland State University, and I'm venturing into the abyss with writing a textbook of all things on psychopharmacology with Dr. Elliot Ingersoll up at Cleveland State. And I had always thought my first book would be some bestseller or something like that, but a textbook on psychopharmacology just wasn't in the plans.
Well, if you write it, if you write it correctly, it might become a bestseller. Depends on what you put in there.
I'm a little too editorial in my writing for maybe some faculty members' tastes, I guess. As far as the ADM board goes, does anybody know what the ADM board stands for? We're trying to roll out some things with getting people's understanding. Don't read it off the pen.
What'd you say, Randy?
It's the Alcohol and Drug Addiction Mental Health Services.
Drug addiction.
And it came into being in 1989, and it's a government subdivision. Ohio has what we refer to as home rule, where some of the funds come to counties, and then counties look around for what the local needs are, because what the needs are for Summit County is going to be different than what the needs are for Licking or Hocking County, and it might be different than what the needs are for Cuyahoga County. So we want to make sure that we can have services that really most clearly fit the needs of what we have locally. So we're a government subdivision, and what we're supposed to do, and what we do, is we do community planning. And what planning is, we do a needs assessment of what are the issues that we really need to address locally when it comes to mental health or addiction. We do the funding, where a lot of federal funds come through here and a lot of local funds. We have a local levy that is 78% of the dollars that go to the services in this community. The other 20-some% are from state dollars or federal block grant dollars, but the majority of it is from local levy. We do the evaluation and contracting of programs. So if Isaac is going to be starting up, and you're listening now, ain't you? You shouldn't wear name tags around me. If Isaac starts a mental health therapy center, and he wants to provide therapy, and he's going to say, I need this much money, and then if you give me this much money, I will treat this many people a year at no cost to them. And we would listen to that. And if it came to where he had the certification and the background and the ability to do this kind of service, we would fund him for that service, but we also want to know if that service is effective. So one of the things that we do is evaluate agencies. With the drug and alcohol agency, one of the things that we want to make sure of is people get sober. Ultimately, we want people to get better. If somebody's doing counseling for depression, ultimately we want people's mood to be elevated. If somebody's struggling with some psychotic disorder, ultimately we want to provide some services that's not going to interfere with the positive trajectory of their life plans. So we want to do what we can to make sure services are effective, because otherwise we're just throwing money at agencies, we're throwing money at businesses, and we're touching a lot of people of look how many people we serve, but nobody's getting better. So what we really want to make sure is with our evaluation if people are getting better or not. We also do prevention services. To give an example of prevention, and this is kind of based in science really, there's a lot of national literature and data out there, and I'm kind of a library nerd, so I might throw some research notions at you. What they find is if somebody doesn't graduate high school, their ability to have a livable wage is diminished significantly. And this isn't like it was in the past. I'm 53 years old. I know there was a time where when I graduated well, even if you didn't graduate high school, you could get a job at Ford, you could get a job at Firestone, you could get into the military. I know Art Modell, the former owner of the Cleveland Browns, who broke my heart, in 1995, and I haven't forgiven him yet. Never graduated high school. Those opportunities aren't available now. If you don't graduate high school, you can't even get into the Marine Corps. You can't get into the Army. You can't get into any college. You can't get in, and without those, even the trade skills, you're not going to be able to earn a livable wage. Now, what would you guys think is the #1 indicator of people not graduating from high school? Besides, not doing the work, not showing up, those type of things.
Would it be addiction to alcohol?
It contributes.
Is it like maybe not living in impoverished areas or having?
It contributes.
Would you form the question one more time?
It would be, there's some key indicators early on that if somebody doesn't meet this benchmark, they have a much less chance of graduating high school.
Yeah.
That contributes too. All those things factor in. But the #1 is, believe it or not, of all things, and I wouldn't have thought of this, is kindergarten readiness.
Kindergarten what?
Kindergarten readiness.
Huh.
The way school works is K through 3, we learn to read.
That's right.
3 through 12, we read to learn. So if you don't master those K through 3 skills, nothing else matters. If you don't know how to read fairly proficiently by grade 3, everything else is based on that foundation. And you're likely to fall back in school, to get into other problems at school, to seek attention in different ways, but the whole trajectory changes. And now what they're finding is kids that don't get the opportunity to go to preschools aren't as ready for kindergarten as kids that go to preschools. So all of a sudden, I'm looking at my children now. My kids go to preschool. They just grew up that way. And there's a lot of people that they don't do that. There's Head Start programs where people in impoverished areas can get their kids into preschool, but there's so much disparity there that some kids get to kindergarten and they're pretty well able to read and do some basic arithmetic. And there's other kids that get to kindergarten and they don't even know which pages to open in a book, that they open from right to left instead of from left to right or upside down. And that bridge right there at kindergarten has been something that changes the trajectory of people from that point forward. So a prevention program bases itself on that principle. So there's a prevention program that we fund locally. It's called the Devereaux Early Child Education Program. And it has a teacher can go and do a needs assessment on kids in daycare from ages 3 to 5 that can change how they teach class to get kids built up to be kindergarten ready. Now you wouldn't think, you're not going to call that a drug prevention program, because then we're going to raise everybody's alarms of, what do you mean you're doing a drug prevention program in my daycare at the bottom of the street? It's not like we had a drug problem there. But we have found that there are some things that we can do that actually prevent, on a pretty large scale, some problems down here, and that's a prevention program. So we do some funding for treatment, which is after somebody has the problem, and we also do some funding for prevention, which is how can we prevent or lower the risk of some people having some problems. So that's just something about the funding. Now in Summit County, we have a population of about 500,000 people. In case Isaac asks, it's actually 544,000 and some change. Don't ask me about the change. So we got 500,000 people down there. Not everybody has health care. Not everybody that has health care pays for them to find services. I've been in this field for about 25 years now. And just so you know, and I'm pretty transparent with it, I don't, open events with this, but how I got into this field, I wanted to be an engineer someday. And I ended up having a drinking problem. And I got into a lot of trouble with that. And I've been sober now, December 27th will be for 27 years. I haven't used any substance or drug or alcohol or anything like that. and kind of went in a different direction in my life to advocate for programs for people that have suffered that same thing. There wasn't a program available for me back in the fall of 1984. I don't know what would have happened. You know, I just don't know what would have happened. But certainly my life wouldn't have taken the direction that it did. But in 1985, insurance companies paid for treatment. And I'll just say adolescent treatment programs, just hospital-based adolescent treatment programs. There was Glen Bay Hospital, had about 80 beds. There was Women's General Hospital that had about 40 beds. There was Edwin Shaw, and this is just for kids, that had about 40 beds, plus they had a residential program called the Marting House that had about 40 more beds that could keep kids there for about 6 months. There was Southwest General had some kids beds, Serenity Hall had some kids beds at West Shore Hospital in Westlake. Oakview had a treatment center that was in Middleburg Heights at Southwest General Hospital. You had Barberton General over here on 5th Street in Barberton. They had a Glen Bay wing, and I think they had about 15 adolescent beds there. They were all over the place. Guess how many there is now? Northeast Ohio. 1. And it's not that the drug problem has gone away. It's that in 1985, insurance companies covered about 75% of the funding for treatment nationally. But when insurance companies pulled back, now it's the public sector. So in 1985, substance abuse treatment was funded by the private sector at about 3/4 of its amount. Now the private sector pays about 25% of the treatment, and the rest of it falls to the public sector. Our drug problem has not gotten better. Now back in the 80s, and here's where I get editorial that you probably turn this off in case my boss sees it, is there was a politician a politician's spouse that started an initiative called Just Say No. Now, the way I look at that is if you say just say no to a drug addict, that I rank that up with saying just cheer up to somebody that's suicidal. You know, it's just a lot more complex than that. There was a federal initiative that if you had a big enough drug problem in your community, you would earn, as an incentive, a Just Say No poster. Well, there you go. I mean, we could just eradicate substance abuse problems in neighborhoods by putting up a billboard of a politician. I mean, and that's where we came from. But that was also at the same time private sector pulled out and public sector built in. There's been some changes with that. With that population, last year, the ADM board provided services to 26,000 people in Summit County. That's a pretty good chunk of people. That's probably greater than the population of Stowe. That's probably greater than the population of most of the suburbs in Summit County. That's a lot of people. And we're primarily working with the people with the most severe problems. This isn't somebody that's, you know, had a couple things go wrong. We work with people that have been suicidal. We work with people that are having psychotic events. We work with people that are homeless. We work with people that are in the depths of heroin addiction, these kind of things. 26,000 people we served in Summit County in 2011. I haven't got the 2012 data available yet. Of that population, 30% of the people we provided services to were over 50. And that number is climbing. It's climbing significantly. And when we get with populations over 50, we're running into a lot of different complex issues that we didn't run before. We're finding out things like doctors don't talk to each other. That somebody might see a psychiatrist that gives them a certain medication, and somebody might see their internist that gives them a certain medication, and as a patient, we assume these two doctors talk to each other, but they don't. And now all of a sudden they're giving us medications that contradict each other on some level. So we're doing some things to coordinate services better. To give you an idea of mental health and addictions, the Surgeon General in 2007 came up with a report that they just did some epidemiological data, and it's a great word. You got to use that in a sentence someday. It's just a killer word to use in a sentence. Tomorrow, just try to epidemiological, and people will look at you like you're a genius. I might not even know what it means. I just say it, and it sounds really cool. But the Surgeon General's office did some studies, and they tried to look at, by our population, how many people have how many different issues. So of America's society, of the 302 million people that live in the United States, how many of them would have a mental health issue? How many of them would have an addictions issue? How many of them would have psychosis? And what the Surgeon General came up with in 2007 is about 20% of people in the United States have some type of mental illness. But that could be mildly depressed, which everybody is on some days or some days not. That could be an adjustment disorder. An adjustment disorder is I'm going through one of those major life issues. If my wife left me and my dog ran away and my cat got syphilis or something like that, it could happen. So if all that happened, and cat doesn't have insurance, so you know that's going to come out of my pocket. I would be depressed. That doesn't mean I'm clinically depressed. That means that there's been a situation in my life that I need to rebound from, because anybody would be depressed going through that kind of set of things. There's people that lost homes, there's people that lost jobs, there's people that marriages are falling apart, there's people that have done everything right for their family and their kids go a different direction than they want them to. A lot of these are some issues that people can work through with some talk therapy and those kind of things. So it's counting those in there too. It says 9% of people in the United States have some kind of substance abuse disorder, which means the way they use drugs or alcohol is interfered with their life in some way. So that could be someone with multiple DUIs, or that could be someone with heroin addiction. So we took those numbers, well, I took those numbers, and I just prorated them against the Summit County population. And what I came up with, according to those figures, we have about 30,000 people in Summit County that have substance abuse issues. We have about 93,000 that have some kind of mental health issues, and we serve 26,000. So there's still a lot more people out there that are needing service. Even with our waiting list for treatment. Sometimes for somebody to get into a residential treatment bed, it might take 4 to 5 weeks. Now here's what we're playing with. What would you guys think the #1 drug problem is in Summit County right now?
Meth.
Why do you say that?
That's what I've heard.
Heroin's coming back really
I
good.
thought it was alcohol.
On some levels, you're all right. As far as crystal meth goes, crystal meth has a lot of people concerned about it because not only is it an abused drug, but it's also an EPA cleanup problem. So if somebody has a meth lab in their house, it gets into the water supply, they're working with all kind of chemicals there, and you can fair to well suspect, and not to be judgmental here, but I would guess, if you got a bathtub lab for meth going on, that instead of taking all those fluids out and then taking them to some hazardous waste company, you're probably just going to open the drain on your bathtub. And then it seeps into the groundwater supply, it seeps into the lake supply and everything else, and we're starting to have problems with that. But crystal meth is the #1 drug of choice in the Pacific Southwest, so if you ever go to Arizona, California, New Mexico, those kind of places, crystal meth is a huge problem. And for you that don't know what it is, crystal meth is to speed what crack was to cocaine. It's just a much more refined delivery mechanism for that particular drug, and people get addicted to it fast. It's not even in our top 8 of drugs in Summit County.
Really?
The #1 drug of choice that we've had on women, adult women hitting our system, if we combine opiate prescription drugs and street heroin, opiates are the #1 drug of choice amongst women hitting our system in Summit County. It's the #2 drug of choice behind alcohol with men. So a lot of people were thinking alcohol you would almost assume is #1, but with women it's #2. And here's some of the reasons. There's a lot of things working together on this. In 1970, now Isaac isn't going to know what I'm talking about. So we're just going to talk over Isaac's head. And who in here remembers the show The Mod Squad?
Oh, yeah.
See, he still thinks of Julie back there. You know, there was Link, Julie, and Pete. I think it was. And everybody my age liked Julie. Any case, when Mod Squad was out, what's that?
I said I didn't know I was gay.
Oh, you had more choices.
I like the curly haircut with brown hair.
I had a black and white TV, so they all had gray hair to me.
We had a Zenith television set.
In 1970, heroin in Northeast Ohio, it's always been sold the same way. It's sold in what they refer to as a bag. Now, a bag is 1/10 of a gram. 1 gram means 10 bags, and that's on the street referred to as a bundle. Now, that's how it's been measured even in 1970 compared to now. So 42 years ago, they measured it. A bag is 1/10 of a gram. A bundle is 10 bags. Now, in 1970, in Northeast Ohio, a bag of heroin was 3 to 5% pure. And it cost $25. Now, today, 42 years later, a bag is $10. And it's 30 to 75% pure. Heroin is hugely powerful compared to what it was. That's one issue. So right now, there's a lot of people that, even in my circles of people that are in recovery, they would say, well, I would never use a needle. They would never say, I wouldn't use heroin. They would say, oh, I would never use a needle. Heroin is so pure now, people don't have to use needles. They can sniff it, they can put it on cigarettes, they can put it under their tongue. It's water soluble. There's a lot of things they can do with it. You know, they just had a heroin bust in Westlake High School in Greater Cleveland. Westlake High School is ranked number 3 in Cuyahoga County for academic performance, and it's in a pretty wealthy community. So that's one. Second one is, there's a new drug that came out by Purdue Pharma. Purdue Pharma is a manufacturer that also is a distributor for cleaning products like Lysol and stuff. So of course they got into the big pharmaceutical market. You know, what better sister company for Lysol than pharmaceuticals? So they got into this, and that was at the onset of a drug called Oxycontin. Now, Oxycontin isn't new. The active ingredient in Oxycontin is a drug called oxycodone. Now, oxycodone is in Vicodin, oxycodone is in Percodan, and oxycodone is in Oxycontin. But it's in Vicodin at maybe 2 to 5 milligrams. It's in Oxycontin up to 80 milligrams. So it's very, very, very pure. And if Isaac is buying a bag of heroin, it might be 30% purity one day. It might be 70% purity the other day. And it's always kind of guessing of what, don't be agreeing to this too. Don't be looking like you know this. Anyway, I just shouldn't have looked at your name. It's just in trouble for the rest of it. But if I'm taking Oxycontin, I know exactly what it is every time I take it. It's scientifically made in a laboratory. Purdue Pharma got in trouble because when the FDA approved this, the FDA approved it for things like stage 4 cancer, for things like acute hemorrhagic pancreatitis, for things that just have horrific pain. But where the company was selling it to was to orthopedic surgeons, to back doctors, to pain clinics, to this kind of thing, and they were starting to give it to people outside of the original intent. There was a big class action lawsuit a few years back, and Ohio was even named in that, where Purdue Pharma was sued, a huge class action lawsuit, and it seemed to be a kind of the cost of doing business, because Oxycontin hasn't gone away. Around that same time, in healthcare, and this is one of the things that people don't know, is that the AMA approved a 5th vital sign. Now, vital signs, when you usually think of vital signs, you're thinking pulse. You know, are you breathing? Is your heart beating? Do you have a fever? Those kind of things, vital signs. But they came up with the 5th vital sign called pain. So around the same time that heroin got real pure, around the same time that Oxycontin got pushed into the market, the AMA established pain as the 5th vital sign. So now every time you go to a doctor, you know, what's your pain on a scale of 1 to 10? So what happens if I go to the doctor and I say 10 every time? Does it mean that my pain is 10, or does it mean that I know if I say that, he might give me something? So we're having this huge prescription drug problem. We're having doctors that are overprescribing. We're having physicians that are talking to each other. We're having a drug craze out there that is in the same family, because heroin and Oxycontin are in the same family. They're both opioids. They work the same way. They have the same drug action in the brain, everything. Pretty much they're the same drug. And now we have people that they run out of their Oxycontin. Now on the streets, heroin is actually cheaper than Oxycontin. Oxycontin goes for about $1 a milligram. Heroin goes for 10 bucks a bag. So I could get a bundle of heroin, 10 bags of heroin, so for the same price as I could get a pill of Oxycontin. So it's a big profit item. And we're seeing problems with that, and it has hit our system. It used to be we would see heroin addicts that are in their 40s and 50s. We're seeing opiate addicts and heroin addicts that are 17, 18, 19 years old. The #1 dropout population of people in treatment are heroin-addicted women between 18 and 25. They still have the sense that, you know, let me just get off of this for a couple days and I'm good. So we had to change the way we do treatment for this particular problem. Now with youth, the #1 drug of choice is still marijuana by about a 9-to-1 ratio over the next highest drug. The way I look at this thing, because I'm a research nerd, is with adolescents, #1 drug of choice by a 9-to-1 ratio is marijuana. But with adults hitting our system, the #1 drug of choice is opiates. Something happens between high school and post-high school when it comes to the use of illicit drugs. And that's just some of the things that we're trying to address locally. With mental health issues, the #1 diagnosis that we're seeing, that we're working with in our system, is mood disorders. When I say mood disorders, that's things like major depression, things like bipolar disorder that used to be called in the Hendricks day manic depressive disorder. And the second largest we're seeing hitting our system is psychosis. And when we get into psychosis, those are schizophrenia. It's when somebody might have, that's when they can have hallucinations, you know, hearing things that aren't there, seeing things, and people can stabilize off that pretty well. There's some medications out there that are remarkable. Back in the 50s, 60s, 70s, and 80s, if somebody was having a schizophrenic episode, they would give them a drug, we'll say like a stelazine or a thorazine, that what it's going to do is going to completely blunt Isaac. He's going to look drugged. He's going to shuffle around. He's going to really look drugged, and we don't even know if he has the symptoms anymore. Inside, all we know is us outside, we can't see it in him. Because he's shuffling, he's drooling, he's calm. There's some medications out there now that are so pointed that somebody with some of these formal thought disorders could take some of these medications, and it's just so pointed to the symptoms that you really can't even tell they're medicated. And some people could go out and you would never know. Dr. Fred Fries, who works for the ADM board, he's one of our consultants. He's traveled the country. Fred Fries is a PhD psychologist and faculty at Neomed Medical School. He also has schizophrenia. And that's one of the things he does. He wants to erase the stigma that when you have these kind of disorders, it's just kind of a sentence that you can never overcome. But there are treatments out there that can help people along with this. We also know that there's issues, and I don't know if you've read the paper, there's a term we're calling it the penetration of people with mental illness into the criminal justice system. In 1990, I'm thinking, there was 4,000 state hospital beds. Now there's less than 1,000. Matter of fact, the one up in Cuyahoga County, which we used to call Cleveland Psychiatric Institute, closed last June.
What was that one?
CPI. There's a hospital called Cleveland Psychiatric Institute. They used to call it CPI for years. It's on the campus of Metro General Hospital up in Greater Cleveland. It was an 80-bed state hospital. It closed last June. So the only state hospital we have now is up in Northfield, Sagamore to be more specific. It's got 260 beds, and it covers Summit County, Ashtabula County, Geauga County, Lake County, Cuyahoga County, and Lorain County. Used to be 4,000 beds, now there's less than 1,000. And part of that is we have medications and we have treatments that are so pointed in their effectiveness that people 20 years ago that used to have to live in a state hospital could live in a community and have their own apartment and maybe even have a part-time job. And that might not seem like a quality of life to you, but for somebody who 20 years ago would have been locked in a room, now they could go out and buy their own gum. Now they could go to the store and buy bread. Now they can pick what they want to watch on their own TV in their own apartment and listen to their own music. That's a godsend to somebody like that. And those are just some of the services that we can provide. You know, we're the only county in the state that has a direct law enforcement drop-off to psychiatric emergency services. There's a place called the ADM Crisis Center, where if Isaac's a cop, we're going to make him a cop now. He has made no decision in his life. So now he's a cop. And he's pulling over his father, which he's been looking forward to ever since he became a cop.
And he had mental health issues, right?
Oh, yeah. Yes, now we give him a gun. But anyway, if he pulls over somebody and they're in a psychotic distress, that police officer can take them right over to the crisis center, and they can take them there and put them on what would be a one-day hold to stabilize them. If they're involved in some community resources, re-engage them with the community resources. And in that building, we have a 14-day unit called the Crisis Stabilization Unit. So we have that available for even local law enforcement. If somebody's drunk and disorderly, instead of taking them all to jail, he could take his father, Lloyd, drunk and disorderly, which, play this one out in your head all the way home. He could take him to the Oriana House drop-in center, and they can keep him till he dries out the next day. And if he wants to have services after that, they can keep him for detoxification or something else. So we have a lot of services here, but the services we have are pretty pointed in what they do. We have the crisis unit. There's a program called SAMI. We're in concert with Case Western Reserve, has something called the Coordinated Center of Excellence. And there's a specific type of treatment that works best for people that have, they call it dual diagnosis or comorbid conditions. So if somebody's bipolar and an alcoholic, or if somebody is schizophrenic and a heroin addict, it can work with that together. And we have a program at CSS that's for that particular population. We have residential treatment. We have the IBH, which is down in the southern part of Akron. We have the Oriana, or we have Raymar. But if all of a sudden, I needed to go inpatient. Let's say I'm a late stage alcoholic, I need detox, but then, I live in a crack house. What's the chances of me staying clean and sober if my home is a crack house? Sometimes we need to remove people from their environment until they can build the skills necessary to be able to say no and be able to get some new friends. So we have some residential treatment programs, and we have about 80 of those beds in Summit County. Even with those 80 beds, we have waiting lists sometimes for 2-3 weeks for people to get into there. So there's a tremendous need. There's something called a FIRST program. We're one of the only places in the state that has a FIRST program, and what this does, it's one of those preventive things, that when people have a first psychotic episode with schizophrenia, we rarely see schizophrenia with people in their teens. Generally, somebody's clipping along pretty well, and then they have what we refer to as their first psychotic episode, a lot of times in their early 20s. Now, it's almost like a stroke. What they say with a stroke is the faster you can get somebody into treatment for that stroke, the less impact that's going to have on their continued lifespan. So if we get people, we have a tremendous amount of, Northeast Ohio is probably one of the best places to get sick in the country, not that I'm giving you all permission, due to some of the hospital resources that we have. But if I had a stroke right now, and I got into services within the next hour, there's a good chance that I could just not have any long-term effects from that. But if I have a stroke now and I don't get into services for a couple days, I could have a lifelong debilitation and even die. How fast we get somebody into services matters. Same thing as with schizophrenia. If somebody has their first episode, the faster we can identify that and get them into resources, the less impact that's going to have on them throughout the rest of their lifespan. These are people that first episode, like I said, usually happens 21, 22, 23 years old. So we have some mechanisms where we can identify people that are having a first episode pretty quick. There's a program it combines Child Guidance and Family Solutions and CSS with some adolescent psychiatry and some adult psychiatry, and in concert with the Best Center at the Neomed Medical School, which is nationally recognized for this. We'll look pretty highly in the rest of the country for having this particular program. So there's a lot of those evidence-based programs. We don't just throw money at agencies. We want to make sure agencies have the type of programs and that type of staff there that has some foundation in research to be able to get people better. I know there's a lot of well-meaning people out there that really want to serve people. We want to make sure that we fund people that can help things get better. So part of the fundamentals of how we operate, we want to have the most efficient and effective use of the resources that are available to us. And we take the role of stewards of public funds pretty seriously. So even with annual reports, or I'm going to leave my business cards here if you want some more materials or some more data on some of these programs, because I'm telling you, some of these programs are actually pretty clever the way they're delivered. And they're remarkably effective with the way they're delivered. This isn't just about touching 26,000 people in Summit County. This is about changing the life of 26,000 people in Summit County. There's a big difference between those two things. Now, if you haven't noticed by now, I can talk for a long time without breathing. So what I'm going to do is just open this up at this point to any questions, concerns, sarcastic anecdotes, anything that you want to have, and I'll try my best to respond to them. Figures.
Well, I was just curious about one of the false things you actually talked about, which was the kids, which was your example of the preschools, and that helps with the overall chance of graduating from high school. So I was wondering, have studies been done to prove causation rather than correlation, just to make sure that it's actually that going to preschool actually causes the help rather than just being an indicator?
What they've done, that's a really good question. Kind of broadside a little bit.
I'll tell you why in a minute.
There's some research done. It's by Catalano and Hawkins back in the 80s. And if you Google that, you can find all kinds of things that is mostly going to be called risk and protective factors. What they did is tell you a bit how Maslow worked. Before Maslow came around, all the personality theorists were illness-based. What Maslow did, unlike Freud, unlike Jung, unlike all his predecessors, Maslow decided that he wanted to look at what is the optimal human condition. What are we truly capable of? Most people know Maslow for that hierarchy of needs, if you got to eat before you could, fall in love kind of thing. What Maslow's really lifelong drive is what is the optimal human condition. And he did research on all these people that were thought historically to be self-actualized and looked at all the things they had. And those were resiliency factors. So we started pointing treatment, pointing therapy of how can we build those resiliency factors. We've done the same kind of studies with prevention. A lot of people think, okay, if somebody is brought up in a very tough neighborhood with very few resources, how come some people, in spite of that, can arise to magnificent success? And what some of the studies done is they started studying those people. What is it about those people that makes them resilient to those kind of community things? And they came up with this list of resiliency factors. They also call them protective factors, and these lists of risk factors. And they work in kind of a construct. Or to give an example, one of the constructs they have in early education And this is for, they studied what are some resiliency effects against somebody developing a substance abuse issue. Now they do know that the number one indicator of having a substance abuse issue is your bloodline. That's just one of those things. It doesn't mean that because my dad's an alcoholic that I'm destined to be, but it means I got a better chance. But when the risk and protective for that early childhood piece, one of them is early childhood aggression versus self-control. The kids that have a lot of early childhood aggression, think about it, have very little patience, have a lot of impulsivity issues, a lot of difficulty in, even having the frustration tolerance to do things like mathematics. Mathematics it's as much about frustration tolerance as it is about, intelligence. If I'm impatient, math is going to be tough for me. It has nothing to do with how smart I am. It has to do with how impatient I am. So when we get into this early childhood, and I'm actually getting to your question. I'm not politicianing around it. I'm trying to be thorough. That's another word you should use in a sentence. I just made that one up. I derailed myself. So one of our early childhood interventions would be, we want to teach self-control to kids that have anger problems in elementary school. So what that means is the causality. If you want to get into causality, we can indicate that it's early aggression and it's impulse control. Can that be sourced in the sympathetic nervous system? Can that be sourced in something that happens in the brain? Probably. But that doesn't mean that we're going to throw a drug at everybody that has an impulse control problem. Part of this is we just have to master certain skills. And patience is a skill that we have to master. It's just the way it is. So there's always going to be something more refined with causality, but ultimately they're looking at things like early child aggression is one. Another causality can be your neighborhood. It's called, there's another causality that they're finding with substance abuse and some mental health resiliencies called childhood mobility, where kids that have the same elementary school and then the same junior high and then the same high school, or however it works now, have more resiliency than kids that are constantly moving. When I was growing up, there was a friend of mine that was what we refer to as a military brat. And I met him in my 20s. And what was different about him, we made fun of him for being a military brat, but if you ask him, hey, how many schools did you go to? And his response would be something like 20. That's a lot of hellos. And that's a lot of goodbyes. And if you go to a high school in California and then you move to New Jersey, the way people talk, the way people dress is completely different. You got to do that every single year. You don't have any lifelong friends by the time you're 20 years old. That's a tough go. So we found a lot of different causalities. So we have to figure out, there's even some studies that you could do. There's something called a risk and protective analysis that you could do, or a communities that care survey, where you can survey all the students in your school, and on this tool that shows all the risk and protective factors, and it will show you your 3 highest resiliency factors and your 3 highest prevention factors. And if we have very limited money, instead of giving everybody $1, sometimes you have to pick the best programs to give a larger fund to that they can make a dent. So we will fund the programs that address the highest indicated risk factor in a certain community. Now, did I answer you?
I guess kind of.
Good.
over here.
How big a factor is, in this scheme that you're describing, is parental supervision?
Parental supervision is indicated as a risk and protective factor. It's one of those things that some prevention programs they teach parenting skills. I was at McDonald's. I shouldn't say this. This just happened recently. I was at McDonald's on top of a hill, and I don't know if it's Market Street or Exchange. I always confused the two, but whichever McDonald's is on a hill, I was at that one. And there's a woman and about 3 kids, all under 5, and they were climbing on the back of the booth. And not that I typically mind that, but it was my booth. So I had these kids, crawling up around my booth like cats. And what she kept saying was, quit climbing, quit climbing, quit climbing, quit climbing. And at some point, I just wanted to talk to her. You do know that is ineffective, right? But that's what she did. Now there's somebody that has supervision. They have eyes on their kids, but they lack the skills and the training and the guidance to be able to be more effective. So it's parental supervision is more than just being there and supervising. I know some parents that are great parents. They're brilliant parents. But by, our society being what it is, dad works 50, 60 hours a week, mom's a nurse and works second shift. The kids are 13, 14. I mean, they got a dual income, but they're just, they're 2 paychecks away from homelessness like a lot of people are. So they don't have any after-school supervision. They're both highly educated, but due to the work that they do, they're never home. So you have 2 parents that you would think would be great parents, but they're just never home. So there's a supervision issue there. And then you have another parent that's face-to-face but lacks the skills. So parental supervision is a huge indicator, but it's got a lot of variability to it. Does that make sense?
Most of it seems to have an economic root, based on what you're saying.
Some yes and no. There are some, there might be some economic roots when it comes to, how I'm actually interacting with my children. But I've seen people of profound success, that their success keeps them out of the house most of the time, where they never see their dad. I know married couples that have teenage kids, and the kids will tell me, oh, I never see my dad. I used to be in a private practice. And I couldn't get the parents to come in because they were always too busy with work. And again, that's a supervision issue. It has nothing to do with their family economics. This was a very successful family. It had to do to maintain their economics. They were just never home.
Tom? Tom was next, yeah.
Okay.
Then the lady over there.
I wanted to get back to Head Start. Hasn't Head Start also in childhood education? Children that go through that are less likely to go to prison.
Children that go through early childhood education it's not going to inoculate people from never encountering any difficulty, but it does give them a leg up. It does give them a head start. But Head Start not being mandatory, and we have a lot of people now that are alienated by public schools in total. I'm not having my kid go to a public school. I'm going to teach them at home. So they never go to school till they go to kindergarten. And something about being around your peers, whether your peers are other 3-year-olds or not, helps you have some of that social interaction skill that you need. And with Head Starts now, when I was in kindergarten for me was about, okay, don't hit each other. Everybody sit in a circle during circle time and pick up your cardboard blocks. Everybody remember them red cardboard blocks? That's all I really remember from kindergarten. And I remember when George Polis hit me upside the face with it. It still hurt. Not that I have a resentment. 48 years after the fact of George Polis. Not every kid goes to Head Start. It is available for some lower income. It is, daycares are available for some higher income, but there's people that are those tweeners that daycare is expensive. And I think with the IRS, I'm just saying this because, I got kids in daycare, is the tax benefit, or whatever you call it, the write-off benefit that they give for daycare is like, for us, we had one child in daycare, and I think our cost was a lot. What the taxes would allow us was 1/5 of that. So we were able to write off 1/5 of that expense. And I think that expense hasn't changed since the 70s. But I'm seeing families now that their daycare expense is worse than the college expense was. Because you have to do what you have to do to work.
Lady over here.
That's okay. I'll
Okay, then we come over here.
Oh, okay.
Yeah, just a quick question. Somebody was curious, is there a secular alternative to AA in the area that you know of?
There is. What I tell people, and I know the audience that I'm talking to, I do. Ultimately, we want to link people with what works best for them. You know, we can't force somebody to go to a certain support group. There are, even with AA, or NA or any of the 12-step programs, they are founded in some Judeo-Christian principles. You're going to hear people say that's not true, but it is. I also know, and like I said, I'm a person who belongs to those fellowships. I got to go to a AA meeting on a Native American reservation in northern Minnesota. They didn't say any prayers. In fact, it was kind of odd because the entire meeting was done in a circle. And everybody had to hold hands the entire, and this is maybe 25, 30 people. Everybody had to hold hands the duration of that meeting. And that was real uncomfortable for me. Because when I talk, especially if I self-disclose, I want to do this stuff, but they wouldn't let go. And there was a real value for that. There are some 12-step meetings that, depending on the culture of that particular group, some are more, certainly more religious than others. But ultimately, it is born from some Judeo-Christian values. There's something called moderation management that came out a number of years ago. There's rational recovery that came out a number of years ago. There are some movements out there. Some are more effective than others. I know there was a movement came out in the 80s, and this was part of my story, and there was a book, and when I was in the military, I think I shoplifted the book. Oh God, you're taping this. But it was called How to Avoid Alcoholism Through the Proper Nutrition. And I found that if you break down the biochemistry and the nutrition of alcohol, it comes down to a B complex, most specifically a thiamine deficiency. So I figured, I ended up eating an entire bottle of Flintstone chewables with iron in efforts to offset my drinking problem. And all I can tell you is there was iron in it and turned my poop black, and I still had a drinking problem. So there are some places out there that there's some highly effective ones. Moderation management used to be one, rational recovery used to be one, but there's a lot fewer and further between. And that's what we run into. There are some internet-based type of recovery programs. But there's something to be said about the human face-to-face interaction and support they can't necessarily get from a website. So it's a conundrum. And generally what a lot of agencies do is they look at the 12-step programs is basically is what works best for most, and it's free. So they're going to tell people about it. As other things come up, they do tell people about those items too. And we also want to look at people's particular beliefs. There was an individual I know that got out of prison. He was sober in prison, got sober there, and he was sober for about 7 years. And when he got out, the adult parole authority said that he had to go to treatment, and he had to go to 12-step meetings. Well, how he got sober in prison was through the Muslim faith. And because there's a belief that pure of mind, pure of body, and he ate right, and all this kind of thing. And peer support he got as well. Now when he got out, they were telling him, no, you can't go there. You have to go to the AA meetings. He was saying, but the AA meetings are in the same night as my support group and meeting with this person over here. So we have to, if somebody is agnostic, if somebody is leans towards a secular thinking, we would try to find what's available in the community, or at least I would try to find what's available in the community that would best be congruent with that belief. I cannot tell you that every worker in every agency thinks that same way. And that's one of the roles of the board, is we need to educate our staff on all the resources that are available in the community, because one size doesn't fit all.
Alan, just before, I don't have a question, but related to what you're saying, for those of you who are interested, the latest issue of Free Inquiry magazine, the cover piece is on activist humanism, and one of the pieces in there was written by, I do not recall his name. He is a retired drug addiction specialist who lives in Florida, and he started a secular drug addiction program in Florida called Skeptics for Sobriety or something like that, and still runs this program in Florida. So there are some secular programs, but there's nothing that I'm aware of like that here in Summit County.
The ones that I look at more is ultimately treatment wants to hand people off to the community to assimilate in the community in their own recovery. So you really want community supports. The first thing I would ask with any agency, whether it's a Betty Ford, which is 12-step based, or whether it's a new program in Florida, is how much does it cost? And if this is a program that wants to charge people, you know, $50,000 to $100,000 for a 20-day stay, that always concerns me.
Well, this program is free. These are a group of volunteers.
Oh, I'd have gone there.
They don't charge for their services.
I know there was Synanon back in the 70s. There's a program called the Seed back in the 70s and 80s.
Yeah.
There are some programs out there. They just, the issue is they're fewer and farther between. Because what you run into in Akron is, AA was founded here.
Yeah.
So, you know, it's considered a pillar nationally. They have Founders Day here that brings in 20,000, 30,000 people from all over the world.
My mother was associated with AA. I used to go to those Founders Day conferences.
So it's just one of those things that since this is the hub of that, I think some of the other ones haven't really got, you know, their legs in under them with trying to find a foundation. Maybe that's something you can help us with.
Yeah.
Oh, my turn. I read articles, I don't know if they're true, but I read a couple articles where the Alcoholics Anonymous was not very successful with most people, and that their record is poor, and that people who sometimes they'll substitute religion as a drug and become addicted with religion to replace the alcohol. I don't know if it's true, but I read a couple articles like that.
What I can tell you is that if you get into an addictive personality type of concept, and if you want to really simplify addictions on some level, at least on the behavioral level, it's got some similarities to obsessive compulsive disorder. There's an old adage that once you get sober, you're going to find you have addictions standing in line. So all of a sudden, I get sober, I start buying instant lottery tickets left and right. I quit instant lottery tickets, I start overspending. I stop overspending, I start getting into the dating circle and getting into all kinds of different relationships.
How about being born again like our previous president?
I have seen people, you don't want to get me started on that. I have seen people fall into some addictions that are very profoundly unhealthy, all in the name of getting better. So when we get into recovery, recovery is longitudinal, that we're always trying to refine ourselves on that. So it's to address that secondary addiction, that tertiary addiction, and those other things that might pop up. As far as the studies on Alcoholics Anonymous, one of the issues that you run into is there is no real published studies. There's a lot of opinion papers and there's a lot of editorial documents. But AA can never be allied with any sector denomination. It's a very nomadic population. It doesn't open itself up to research. Now, there are people that are court ordered, and that's where we might run into some issues. If I'm court ordered to AA and I don't want to go and I don't want to quit drinking, it's not going to work for me. I'm just going to drink. I'm going to drink so this meeting's over. So how can you discern which people are serious about it and self-immerse versus which people are coerced into it, and it really complicates that.
Yeah.
There is
Sorry.
Oh no, that's fine.
Okay, Randy, we have one over there and then Randy. Okay?
I'm just gonna
This is kind of related to that. Also, when you started off, you talked about different programs you fund and that you like to evaluate how effective they are. So I was wondering if you could talk some more about what criteria you use to evaluate a particular program and whether or not it's effective.
Some of them come up with their own pre-test, post-test. There's some, let's say the Forensic ACT team. ACT stands for Assertive Community Treatment. national literature is going to say that some of the things that ACT does is it lowers arrest rates, it lowers recidivism, it lowers hospital bed days, and it increases self-efficacy. Nowhere in there does it say somebody's going to be more cheerful, but those are the outcomes that it provides. So we're funding in a forensic ACT team because we know one of the things that we want to do is stop or diminish the people that are having psychotic episodes for ending up in the jail, and this is something that has a proven effect on them. So when we introduce that program, there's something called program fidelity. That if Isaac's counseling, boy, can you write any smaller? Man, okay. If Timothy comes to me for counseling and it doesn't work, but he goes to Isaac for counseling and it works phenomenally, all things being equal, what is it that Isaac's doing? Is there some skill or some style that he's doing that if I did it the same way, it works? So Isaac teaches me to do it the exact same way he does, and then when Timothy comes to me, he gets better. So the closer I do it to the source, which is called fidelity, the better chance that there's an outcome. So what we've done is we've gotten these national models like the ACT team or the SAMI IDDT or these kind of items, and there's fidelity monitoring that says, okay, you have to do it this way, in these many days, with this type of staff, with this kind of medication, and if you do it this way, you should get these outcomes. And we look at the outcomes, and we just measure it up against the research. You know, after a year, did this person have lower arrest? Did they have less hospital bed days? Did they have less crisis presentation? There's also skills like the PHQ-9. PHQ-9 is a depression inventory. It's a 9-question depression inventory, where if all of a sudden Nick's seeing me for therapy, first visit he comes, I'm going to have him do the PHQ-9, and then maybe after the 8th session, I'm going to have him take it again, and did his mood elevate? There's another tool called a GAD-7. It's a generalized anxiety disorder scale. And these are all public domain. We could do the Beck's depression inventory, but it costs us a fortune. We just do the public domain. So if somebody's struggling with anxiety, we can measure a before and after. So there's a lot of things that we measure before and after with, and sometimes it's client self-report. With some of the medication, do you feel better?
Okay, we took up time for Randy. Had his hand up.
Well, I've got a comment and a question.
Oh, I didn't see Andre. That's right.
Well, I think we got time to. Mine will be real quick. First of all, on the AA thing, it's, having had a long association with AA, my mother was a recovering alcoholic. AA does work for those people that it works for. What you were saying earlier, part of the reason why no statistical research has been done on AA is because, first of all, although AA does have a kind of a nationalized program, it's also very decentralized. And then the other thing is that at the national level and even at the decentralized local levels, AA refuses to share its actual information with others. They will tell you how many people have recovered, but what they don't tell you is how many people went into the program. So you don't know what their failure rate is. Now, that given, because of the refusal to participate, and part of it has to do with their privacy issues, but there have been some studies. In fact, Free Inquiry magazine did a piece on it a couple years ago, and the numbers vary, but some speculate that only about 20% of the people who go into the program actually come out of the program recovering from alcoholism, meaning that they speculate that AA's failure rate may be as high as 80%. Okay, even if it's not 80%, it's fairly certain that it's pretty high. But it does work for those 20%. It's very effective for those 20%. My question
You give me a program that's free.
Oh, yeah.
That solves 20% of cancer.
Well, yeah. No, I'm not dissing it. I'm just saying that part of the reason why we don't know what their failure versus success rate is because they won't share data.
In truth, and I don't mean to get defensive about it, but the reality is, AA meetings, every single one of them is autonomous. They don't keep attendance.
Yeah.
They don't keep anything like that. There's no data to be had. It's completely autonomous.
My question I wanted to ask you was, with all the controversy the last couple of years, and most recently with the Supreme Court decision, is there anything in the new health reform law that